Now to the first series of presentations that speak to how Cayman is bridging the gap between patient and practitioner. And that starts with evidence-based information, specifically on public health challenges in the Cayman Islands. This presentation will be by National Epidemiologist Rachel Corbett. She'll be followed by our Chief Medical Officer, Dr. Nick Gent. He was appointed CMO in October 2022 and has extensive experience working for the European Union, the World Health Organization, the World Bank, and the UK Department for International Development in areas including advice on legislation concerning human rights, public health, health services and health regulations, preparedness and response to major incidents, disaster relief coordination, restoring and developing public health systems, and developing healthcare services. The Cayman Islands and the medical community has indeed felt his positive impact over the past year. We'll hear from Dr. Gent in a bit, but first I'll hand over to Rachel for her presentation.
Good evening. Thank you. My name is Rachel Corbett, and this is my second healthcare conference here in the Cayman Islands. If you were here last year, you might remember me speaking on the opening night, and I focused on non-communicable diseases and talked a bit about what we know from our national data here in the Cayman Islands. And to be honest, it was a bit of a sad story of our data being quite out of date and there being quite a few gaps in our knowledge. Well, tonight I'm really pleased to be giving an update 1 year on. National data is still a huge challenge for us here in the Cayman Islands, partly due to our hybrid public and private healthcare model. It's quite difficult to collate data from all different providers. And then when we are able to, because we don't have a national identifier, it's quite difficult to not count people multiple times if they're seeing different healthcare providers themselves. However, we've had two great successes in the last year, so I'm going to share with you some data from those, and in turn they highlight some challenges that we have that we can take forward to find some solutions for through our public health interventions. I don't have any riddles for you, and I don't have any exciting magazine covers, but I do have some charts and graphs which I find just as engaging, so stick with me. Okay, let's launch right in. So the first data set that I'm going to be sharing some findings from with you tonight is the non-communicable disease surveillance that our colleagues at the Public Health Department have been looking into. And they've been gathering some data that covers 6 years from 2016 to 2021. And this mostly focuses on patients who attend HSA services, so it's not looking at national coverage. And this pulls through information from patients using their ICD-10 codes, and this is particularly focused on diabetes, is what I'm going to share tonight. So to launch right in, this graph here shows you the number of patients who received at least one consultation relating to their diabetes at HSA each year. So you've got along the x-axis, on the bottom, you've got the years from 2016 along to 2021. And then on the y-axis going up, you've got the number of patients. And in light blue, you've got female diabetic patients, and in dark blue, you've got male diabetic patients. And just to note, this has been done looking at analysis 1 year at a time, so it's quite likely that an individual will be counted in multiple years shown here. But what we were able to pull out was that there are 5,711 individual patients who are included in this analysis. And a couple of key things to pull out from this graph. It's showing us that the number of patients is increasing over time. Now, with our growing population, that's not particularly surprising, and that's probably what reflects most of that increase. But probably of more interest to note here is that we have more female patients than male patients, and you'll see that is happening every year, that the light blue bars are higher. And we've got a ratio of 1.5 female patients to 1 male patient with diabetes. Now, we wanted to have a little look at advanced development of disease with this. So we had a look at patients, diabetic patients who require amputations. So between 2016 and 2021, a total of 76 diabetic patients required an amputation. And if we take the most recent year of data in this, so 2021, and break it down by sex and have a look at the rate of amputations that are occurring, we can see that among male patients, there's an amputation rate of 4.7 amputations per 1,000 diabetic patients, and among females, an amputation rate of 1 amputation per 1,000 patients. Now, this comparison for 2021, the absolute numbers that are included behind these rates are quite low, quite small, but the same trend comparing between males and females is true in all of those 6 years of data that we've taken a look at. And then we had a slightly more in-depth look to see what age people are having these amputations relating to their diabetes. And so in this graph here, you've again got the years along the bottom from 2016 to 2021. And then now the y-axis has changed to be what the average age was in that year of either female amputees or male amputees. And what we can see, though, the average age range in a year for amputations for women ranged from 67 years to 82 years when they had their amputation. And for males, this was 63 years to 70 years. So what this is showing us is that men require an amputation relating to their diabetes at a younger age than women. And this is true for all of the years apart from 2019. You'll see it's much more similar. Then taking a step back and just seeing, okay, well, this is what we're seeing in some of our data here in the Cayman Islands. How does this align to what we know globally about diabetes and diabetes patients? Well, the Global Burden of Disease study, when looking at this on a global scale, found that the burden of diabetes among males and females is actually very, very similar, and they haven't found there to be a significant difference. There is some research that presents that slightly more men are diagnosed with type 2 diabetes than women, but overall it looks to be a fairly similar trend in both sexes. There's also been a meta-analysis that looked to see what the global amputation rate is per year and broke that down by sex. This is something that we can compare our results to. And this meta-analysis, pulling together lots of different studies around the world, found that among women with diabetes, there was an annual amputation rate of 83 amputations per 100,000 women and 178 annual amputations per 100,000 men with diabetes. So if we just go back to the numbers I showed a minute ago for the Cayman Islands and see how these numbers compare. This table gives you that comparison. So if we consider females, the global rate that I've just shown, if I've scaled it down to 1,000 patients, is 0.83 amputations per 1,000 diabetic patients. And what we had found in the HSA data was a very similar amputation rate of 1 amputation per 1,000 patients. However, if we look at males, there's a much bigger difference here. So globally, there was found to be an amputation rate of 1.78 amputations per 1,000 patients, but the HSA data showed this to be 4.7 amputations per 1,000 patients. So what can we take away from this analysis? Well, there's a few findings that we've got. So firstly, we've got more female than male diabetic patients, and this is contrary to what global data tends to find. We've got a higher amputation rate among males than among females. And we've also got amputations happening at a younger age in men than women who have diabetes-related amputations. One thing we do need to note in this that we haven't been able to include yet is when patients were first diagnosed, and that's a really important aspect to be able to understand in their care pathway where along the process maybe they haven't been able to receive the right care and treatment that they needed and therefore have ended up requiring an amputation. So we don't have the full picture here, so we're limited in what we can say, but there's some hypotheses here to consider. We may have undiagnosed and or undertreated diabetes among males. Males may be presenting later in their disease progression, therefore have a higher likelihood of requiring an amputation earlier in life. And there may be numerous factors that are impacting the effectiveness of diabetes care here, and many of those could be behavioral, which is quite a challenging area to interact with and try to change, but some things there to think about. Now, the second success that I'm going to share some data with you this evening is from the STEPS National Health Survey that the Honourable Minister Turner referred to earlier this evening. This is hugely exciting to be able to share with you. It's been just over a year from when our steering committee first met to plan the survey to today when we're able to share results with you, which is a huge achievement. And I'm just going to share a couple of statistics with you about diabetes and about obesity as well. For those of you who aren't familiar with the survey, I'll just give a quick overview to give you some context. It's a survey designed by the World Health Organization to assess the prevalence of non-communicable disease risk factors. It uses a standardized approach in many countries around the world, so it can be comparable. Individuals are randomly selected from the population and invited to take part. We conducted it in the Cayman Islands back in 2012, and then this summer we've repeated it just over 10 years on across all 3 islands. Taking part in it is completely voluntary, and those that are eligible are residents aged 18 to 69 years. It's called the STEPS survey because it's got 3 different steps or stages. First of all, questionnaire, which looks at a number of risk factors relating to lifestyle choices, so things like tobacco use, alcohol use, diet, exercise, but also engagement with healthcare services, particularly preventative care. There's then some physical measurements that take place at the same time, including an individual's blood pressure, their weight, their height. And then finally, the third step happens at a separate occasion and is a finger prick blood test to measure for blood glucose and cholesterol. And that's a fasting measure, which is why it happens at a separate time. And some of the disease risk factors that are included, I've mentioned a few already, are behavioral, and then others are biological risk factors, so things like being overweight or obese, having raised blood pressure, raised blood glucose, or abnormal blood lipids. So just before I launch into the results, I'm just going to give you some context to what this sort of data can mean for us. So we have national estimates from this survey, which is very exciting, and this reflects residents in the Cayman Islands who are between that age range I mentioned, so 18 to 69-year-olds. The data that I'm sharing is not relevant to those under 18 or those over 69 years. We have weighted our results by age, sex, and district, so that it is representative of the Cayman Islands as a whole. And these are estimates, unless you take a measure from every single person in the population. If you're doing a sample like we have done, then the results that you have are estimates, so you need to interpret them with a 95% confidence interval. Just to give a bit of understanding for what that is, it basically means that we are 95% sure that the true measure, so say if you wanted to understand the average height of everyone in this room, if you went around and took everyone's height and calculated the average, that's your true measure. But if you haven't got the time and you just take a random sample, then you've got your estimate from that sample. And doing that sample, you're 95% sure that the true population measure is within your 95% confidence interval range. So it's somewhere between those points. You think it's at the estimate that you've got, but it's somewhere between that range. So first of all, I'm going to share some data on body mass index. This is a really helpful tool to understand whether somebody's in a healthy weight range. It basically comes from looking at your height and your weight and putting them into a calculation to come up with something called BMI, body mass index. And on the bottom right, you've got a definition of where those categories come from. And what you can see on the screen right now is the 2012 results. And the results that we got from that survey showed that 70% of the population were either obese or overweight. And now you're seeing green is the updated results from the 2023 survey. And what's interesting is essentially things have stayed very, very similar. And currently 69.6, so very close to 70% of the population are either overweight or obese. What you might notice is there's been, if you look at the overweight, you can see that the green bar is slightly higher. So 2023 result of 37% is slightly higher than in 2012. And then looking at the obese bars on the chart, we are now at 33%, which has gone down from 37% in 2012. So there's been a bit of a shift there. But I would caution from getting too excited about that being a positive result. We need to take a look deeper into this data to see whether that shift is significant. And these are just preliminary results. So bear with us with that. We have taken a bit of a further look to look at BMI by sex. So this chart here is from the 2012 data, and in the blue bars you've got men, and in the orange bars you've got women by different BMI categories. And right next to it on the right is an update from the 2023 survey. And essentially the pattern is very, very similar. And what you can see is that a higher proportion of men are overweight than women, but a higher proportion of women are obese than men. So moving on to look at raised blood glucose. The 2023 STEP survey has found that we have a prevalence of 7.7% of raised blood glucose, or of individuals who are taking medication to lower their blood glucose. This is a particularly exciting result to be able to have because in the 2012 survey, the response rate was insufficient for the final step. So this is the first time we've ever had this indicator for the Cayman Islands nationally. And we've taken a bit of a further look, not just looking at the results from the finger prick to see what the levels of blood glucose was, but to also combine this with whether an individual had ever been diagnosed to have raised blood glucose or whether they were on treatment for it. And what our preliminary results are showing is that 7.8% of the population, which is about 1 in 13 individuals, are diagnosed and are on medication, which is good news. And an additional 4.9% of the population, which is around 1 in 20 individuals, are diagnosed but are not currently on medication. And a further 1.7% of the population, which is around 1 in 60, have raised blood glucose and have never previously been diagnosed. And this is a particularly interesting finding of that hidden burden of disease where individuals aren't aware of their disease status themselves. To make this a little bit more meaningful, I've taken those 95% confidence intervals that I referred to earlier and turned this into an actual number of people in our population, looking at our 18 to 69 population according to our census statistics. So this would mean that we have somewhere between 3,200 to 5,200 individuals who are diagnosed and on medication. It would mean that we have somewhere between 1,800 to 3,500 individuals who are diagnosed but are not currently receiving medication. And we have between 450 individuals and 1,400 who have raised blood glucose but are unaware of this. And these results present some of the challenges that we have in public health where individuals are not currently receiving the right care or right treatment. There are many factors that will be at play there, but this really helps us understand where we need to target resources, where we need to change our interventions to meet those most at need and ensure that they're getting the right care. So what are some of the key messages from this preliminary data? And I will just caveat, this is preliminary, so if the results come out and things shift a little bit, then that's very understandable. These are that the prevalence of obesity or being overweight remains high and hasn't shifted that much since 2012. That the prevalence of obesity is higher among females than males, and the prevalence of being overweight is higher among males than females. 5% of the population are diagnosed as having raised blood glucose but are not on treatment currently, and 1.7% have not been diagnosed for having raised blood glucose. So these are things that we can take away and look at and see what we can do to improve. This is just a tease of some early information that honestly is hot off the press and we've been analysing earlier this week. But there is much more that is coming soon, so we'll be looking into both of these data items in more detail, but there will also be information on the prevalence of total cholesterol and HDL cholesterol in the population, how that ratio interacts. We'll be looking at raised blood pressure, tobacco use, alcohol use, diet, physical activity, individuals' history of different conditions and their engagement with healthcare services and screening services and how recently that happened. So there is a wealth of data that we now have that we can use to inform our policy moving forwards. So keep an eye out for that coming out next year. And I just love this opportunity to say a huge, huge thank you to many people that were involved in the survey. I don't know if there might be people in the room that took part. Thank you very, very much. If someone came knocking on your door and you said yes, we're hugely grateful to be able to have this information, and you've made that possible. So thank you. Our team of enumerators and nurses, I've actually seen quite a few of them already tonight at the event. You did an incredible job out in the fields, and a really, really superb team. For our supervisors and ministry support staff who were there behind the scenes making it all happen along the way. We had some great support from PAHO, the Pan American Health Organization, along our planning stages and with our training. And also a thank you to our stakeholders who helped to publicize and to get the word out about the survey happening, engage with their networks too. Thank you very much. And I'll now pass over to our Chief Medical Officer, Dr. Nick Gent.
Thank you very much, Rachel, for setting that scene. So what do we make of these preliminary data from the STEP survey and the related diabetic complications data? And please forgive me if anyone feels uncomfortable about the remarks I'm going to make in the following talk. But as the Chief Medical Officer of the Cayman Islands, it would be morally wrong and professionally unethical not to do so. My comments are going to be about the epidemic of obesity that we are suffering here. I looked at the data that's been presented by Ms. Rachel, and I asked myself 4 things. Firstly, should we be reassured that the prevalence of obesity has not changed significantly over the last 10 to 12 years? The second thing I asked was, should we reassure ourselves that we believe that our obesity levels are normative for the region of the world that we live in? Thirdly, should we be reassured that there are medicines supposedly available to control obesity available to us now? And finally, should we reassure ourselves that obesity-related disease, such as diabetes, is amenable to clinical care? As an epidemiologist, I look at the fact that over the 12-year span between the STEP surveys, that only 1/3 of the population has had, during this period, a healthy weight. It tells me that we have become used to obesity being the norm, and we have accepted it as an established fact of life. It also tells me that this is not just a generational problem, but there are underlying these spot findings multi-generational cohorts of people with significantly unhealthy weight. We cannot take reassurance that the proportion of people overweight or obese have not changed in the last 12 years. It's maybe a sign that this epidemic has reached its peak, as many people think. It's not that. It's simply that it's almost impossible to achieve a higher prevalence of this disease, and obesity is a disease. The cohorts of overweight people are leading to an inevitable growing burden of disease and disability that is destroying the quality and quantity of life for too many Caymanians and their families. Cayman is not alone in facing this problem. The global burden of disease due to obesity has been rising in most, if not all, countries for over 30 years. In 1990, around 4.5% of deaths were attributable to obesity. This rose to 8% globally in 2020 and is much, much higher in countries such as the Cayman Islands. And there is no evidence that this trend is slowing down. However, where Cayman stands out is that this problem has been with us for longer than many other affected regions of the world, and the very high local prevalence of these problems. Few other countries can claim that 2/3 of their population have unhealthy weights and 1/3 of their population are dangerously overweight, and that this has been the norm for so many years. Although in fairness, many other countries are catching us up. On this problem and issue, we stand hand in hand with the United States. I suspect that we have inherited their diet and we have inherited their behaviours. We certainly import their highly processed diet. When a child asked what is a traditional Caymanian diet answers Burger King and KFC, then we are in very great trouble. The other American disease that is affecting the Cayman Islands is the medicalisation of health. And in the management of body mass related issues, the Cayman Islands might as well be mainland USA. By this, I refer to the tendency to seek easy solutions to behavioural problems that involve the use of pharmaceutical agents and surgical interventions. Changing lifestyle is not a decision that many people choose to take here. Ask yourself, why risk the complications of bariatric surgery when a conservative approach to treatment is as effective and can be more sustainable? Surgery does not change behaviour, and whilst it gives some people long-term body mass control, for many it is a stopgap and it is not risk-free. Similarly, there is a clamour for the latest wonder medicine, the glucagon-like peptide receptor agonist semaglutide, also known as Ozempic and Wegovy. These are not trivial medicines. They can have significant side effects. The widely quoted study by Wilding et al. Showed that, yes, weight reductions of around 17% were achievable over 68-week treatment courses, but the adverse effects rate was 90%, with serious adverse effects in 10% of the trial participants. But more significantly, such medicines may not offer the long-term solution that people hope for. The less quoted extended study of what happens when treatment with semaglutide is discontinued shows alarmingly fast return of body mass, such that 1 year on from stopping treatment, only 6% of the net weight loss remained, with an almost complete loss of benefit for most markers of cardiometabolic improvement. If I was to summarise this one threat to our lives in the Cayman Islands, it would simply be that we have become a society where obesity is the norm. We have rationalised our fears of the threat to our health, relying on our belief that the consequences are treatable, and we resist taking personal responsibility for our own lives. And if we believe that the consequences are treatable, look to the nuance of some of the data on diabetes that Ms. Rachel presented. To be treatable, disease must be detected, and between 450 and 1,400 Caymanians have undetected and so untreated disease at this time. To be treated, then people must have access to affordable care. Currently, between 1,800 and 3,500 Caymanians know they have disease, but it is untreated. And for treatment to be optimal, then care must be delivered through well-defined care pathways using appropriate clinical services with good outcome data. Not something I am confident happens for a large proportion of Caymanian diabetics. These are typical areas where we must adopt public health-based management strategies. It is why I'm a strong advocate for the Cayman Islands getting and benefiting from a strengthened, independent public health service. We cannot afford the cost of epidemics such as obesity, and the consequent ischemic heart disease and diabetes. And for avoidance of doubt, when I speak about cost, I do not mean the financial consequences, significant as they are, but the cost in terms of quality of life lost and premature death. Thank you.